I want to talk specifically now about the individual coronary vessels when we're looking at myocardial infarcts on the ECG, starting with the right coronary artery. You recall from the last presentation, I indicated that the three primary arteries that we're going to be looking at on a 12-lead ECG are the RCA, the LAD, and the circumflex, and of course, the left main coronary artery, which is a short vessel that rapidly divides into the LAD and the circumflex. But to begin with, let's talk about the right coronary vessel. So the right coronary vessel comes off the base of the aorta, just like the left main coronary artery, and it travels along the AV sulcus. So this is the groove between the right atrium and the right ventricle, and it feeds the right side of the heart. And this is important because when a patient occludes their RCA, they may experience a right ventricular infarct or right ventricular ischemia, both of which can compromise contractility of the right ventricle. And the RCA also feeds the SA node in most humans and the atrioventricular node in about 90% of the population. And this is very important as well because if the SA node is ischemic, the patient may experience sinus bradycardias or periods of sinus arrest or sinus block. And if the AV node is ischemic, this patient may develop AV blocks, second-degree AV block type 2, third-degree AV blocks, complete AV blocks, and that may be a problem as well. And ultimately, the RCA travels around the back of the heart, feeding the right ventricle and the posterior wall of the right and left posterior ventricles. But ultimately, the RCA terminates around the inferior wall of the left ventricle. So on the electrocardiogram, an occlusion of the RCA manifests itself in the form of an inferior wall infarction, and this is very important. So when you see an inferior wall infarction on the 12-lead ECG, and we'll talk specifically about what signs to look for on the electrocardiogram later for an inferior wall MI, then we want to consider the possibility that there may be a right ventricular infarction, because you'll recall that the RCA feeds the right ventricle as well. Even if there isn't electrocardiographic evidence of an RV infarct, we should anticipate that there may be some right ventricular dysfunction because if the right ventricle is ischemic, isn't receiving adequate blood supply, that's going to affect cardiac contractility. And we also want to look for posterior wall infarctions in the presence of inferior wall MIs. Now, I want to talk briefly about acute right ventricular infarcts associated with inferior wall MI. So whenever we see an inferior wall MI, a gold standard is we have to do right-sided precordial leads to see if there's evidence of an RV infarct. This is considered the gold standard in the hospital. It's also considered the gold standard in the pre-hospital setting. And so we do a 12-lead ECG. If we see an inferior wall MI, we do right-sided precordial leads, and I'll talk about placement of those leads later. And if there's evidence of an RV infarct, the patient with an RV infarct will present in a way that is different from an acute left ventricular infarct associated with failure. So when a patient has left ventricular failure, they present with pulmonary edema. With acute right ventricular failure, they don't have pulmonary edema because you'll recall that the right ventricle pumps blood to the lungs. And so if the right ventricle is not pumping adequately, it's not a matter of blood backing up in the lungs, blood will back up systemically. So what we see in acute RV infarcts are patients who are typically hypotensive. Their heart rate will be normal to slow. Remember, they may be slow because the SA node is ischemic or because the inferior wall sits on the diaphragm and the vagus nerve travels along there. And so if the vagus nerve is stimulated, that may cause bradycardia. And the chest is clear. This is an important distinction between an acute right ventricular failure and acute left ventricular failure. The other thing we'll see if the right ventricle is not pumping adequately is blood may back up into the neck veins, so into the superior vena cava, and that may ultimately result in jugular venous distension. Now, the treatment for acute RV infarcts is different from left-sided failure. Right-sided failure is treated with fluids. So we give them fluids because contractility is determined by Starling's law. So the greater stretch of myocardium, the greater the force of contractility. So if we give fluids to these patients, we increase preload. That increases the force of contractility of the right ventricle, and that ultimately increases cardiac output. And we have to continually monitor that they don't go into a left-sided failure by ensuring their lungs remain clear.